everybody. Good morning. I didn't realise I was supposed to introduce, so hello, I'm Vivian. Marlene is going to be doing this talk with you. I've worked with her at Westmead and we worked together with the melanography sessions with the high-risk melanoma clinic and then later with one of our clinical trials. And now she's moved across to the Royal North Shore Hospital and she's very likely continuing her work there. So I'll let Marlene explain everything. I've seen what her slides are going to be about. It's an excellent, excellent talk, so I hope you enjoy it. And here's Marlene.
Thanks, Vivian, for the lovely introduction. My name is Marlene, the Dermatology Research Fellow at Royal North Shore Hospital. And as Vivian has mentioned, I have had the opportunity previously working at Westmead with two lovely melanographers, Kim and Vivian, who are in this room today. And today I'll be talking about lesion recognition in melanography. So I'll be talking about the overview of melanography and the kind of workflow that is involved in the work of a melanographer, as well as how melanographers can work effectively with the medical team. So what is melanography? Melanography is a practice or process involving skin assessment and lesion imaging to facilitate the monitoring of skin lesions and the detection of skin cancers. And I've highlighted the word facilitate in bold, and I'll explain a bit later of why this is so crucial. And why do you need to know this, or why are we in this room? So if you're already a melanographer, hopefully I'll be able to share some tips and tricks that I have learned along the way. And if you are not yet a melanographer but interested in becoming one, hopefully this will be a good introduction so that you know what is involved in the work of a melanographer. And regardless, skin assessment and lesion recognition are really valuable skills to have as a dermatology nurse. So let's just imagine, I think the best way of approaching this sort of talk is that just imagine that you have a patient with you in the room already booked for you as a melanographer. What do you do? So you don't have to take the patient history, but I personally think it's always really good to know what kind of patient you are dealing with. Are you dealing with a high-risk patient or low-risk patient? So the way that I think will be easy to assess that is to assess their risk factors. And when we talk about risk factors, there are two easy ways of thinking about it. So internal or intrinsic risk factors, the things that the patients have intrinsically that can't be changed, and externally. What is it around the patient, the environment that sort of increase their risk of having skin cancers? And when we talk about factors, so we talk about risk factors as well as protective factors, and I think this will help you to just sort of give you an overview whether you are dealing with a high risk or low risk patient. So intrinsic or internal risk factors, so things like CDK and 2A or CDK4 mutations, they are genetic mutations that significantly increase your risk of having melanoma. So these kind of patients, when they come to the clinic, it is not infrequent to see the patient's mom and the patient's grandma or the whole family. Often they will be booked together and then you will, oh yeah, I know your mom or I know your grandma. And so patients who have had multiple melanoma and non-melanoma skin cancers in the past, they're at high risk of having more skin cancers in the future. Family history of melanoma and lighter skin type, so we're talking about normally Fitzpatrick type 1 or 2. So in dermatology, when we talk about skin type, we talk about Fitzpatrick skin type. So I've got some pictures over there. Phototype 1 to 6. So phototype 1, think about red hair, fair skin, lots of freckles, burn easily, and you sort of go up the ladder as you approach phototype 6. So the easy way of thinking about it is, you can ask them, do you tan or do you burn easily? Or do you get a light or deep tan? And ask them what is your original hair color if they are in the older age group. So patients with dysplastic nevi, so dysplastic nevi are irregular looking moles, and I've got some pictures a bit later on. So these patients, they're at a high risk of having melanoma. So when you talk about external risk factors, ask them about their occupation, past and present, because that's relevant. You know, they may be working indoor, but they may have been working outdoor for many, many years in the past. Hobbies or lifestyle, you know, where they grow up. Did they grow up in the country, near the beach? Do they go to the beach every day? Surfing, that kind of thing. Previous sunburns, especially if it's blistering sunburns. So ask them, have you had bad sunburns where your skin peeled, for example? So because when it's blistering sunburns, you know that the degree of the damage is deeper, and that significantly increases your risk of having skin cancers. And previous solarium use. So solarium is no longer legal in Australia now, but we know that just one session of solarium significantly increasing your risk of having melanoma. So that's all about risk factors, just sort of like the basic, and ask them about protective factors as well. So darker skin types you can just observe, and sun protective measures. So wide brim hat, long sleeves, SPF 50, and reapplication. So you've talked to the patient, you have a good idea, but okay, I'm dealing with low risk or high risk patient. So normally, these are some pictures of when I work at Westmead. So normally what we do is we do, the melanographers will do a total body photography. So some centers will have 2Ds, the most common machine is Photo Finder. Some places have Vectra or the 3D machine. The Vectra machine is currently in a clinical trial, so it's an Australia-wide clinical trial. And the aim of doing a total body photography is basically you do them at baseline, and then at patient subsequent visits, you do them again. And you want to compare, every time the patient comes, you want to see if there is any new or obviously evolving lesions. So the lesions that are getting larger, they are getting darker at their subsequent visits. And as I've mentioned, the machines vary across facilities. So with the Photo Finder, you normally ask the patient to do a few different poses, but the 3D machine, the Vectra machine, is actually pretty good. It takes around maybe less than 10 seconds for the patient to just stand, and so inside that machine, there are hundreds of cameras, so the patient, it will be taken from all different angles, and the machine will create this 3D avatar. And you can sort of, if you have worked with this, you can actually play around on the screen, and you can, I've got some picture, but you can actually go to a really high definition where you can see the patient's pose, for example. So that's the total body photography. So you've done the total body photography. What do you do next? So normally what the melanographer will do is doing a general skin inspection. So this is very different from actually doing a skin check. So you do a general skin inspection for the purpose of you want to decide which lesions you want to monitor or you may be concerned about. So I think it's always good. Every person has their own different way of doing this general skin inspection, but do it in a way where you wouldn't, just do it the same way every single time so that you have a good system. The way I do it is I do it head to toe, and I do the front first and then I do the back, and always, remember the web spaces. You can have moles on the palms and the soles as well. And so ask the patient to undress to underwear. And ideally, there should be no nail polish. So if you have nail polish remover and the patient has nail polish on, it will be ideal to remove it. So the easy mnemonic that I'm sure most of you, if not all of you, would already know is A, B, C, D, E. Again, this is sort of to determine, okay, I want to monitor all these lesions. So A for asymmetry, B for body irregularity, C, color variation, D, so larger lesions, especially the ones that are above 6 millimeters, and E, evolution, is really for subsequent visits, so it doesn't really apply if it's at the beginning, at your baseline visit. So this is just an example of a picture where it ticks sort of all the boxes, where it's quite irregular, it's quite large, the color is variable across the one lesion. So I just want to reiterate that just because it's irregular doesn't mean everything is concerning. So when we talk about lesion recognition, I'm sure you have heard about ugly duckling. So spotting that ugly duckling, but one's ugly duckling may not be another's ugly duckling. And you will pick that up in your in your inspection. So some patients, they have a lot of irregular looking nevi. I'm sure you have seen this on your patients before. And if you look at all of those different lesions, especially with your dermoscopy, and they have like similar patterns, so normally we don't worry about the ones that look the same as the rest of their lesions, if that makes sense. And so the ones that you're interested in is the one that is uniquely different for that particular lesion. So for this one, for example, you can see that most of them are not quite round, but this one I will be worried about, and I will monitor, or if I'm really worried, I will escalate it to the managing doctor. And because, some patients have this kind of back, you don't want to monitor all of them. So pick and choose the ones that are different, the ones that you think need to be monitored and may become worrying down the track. So when we talk about dermoscopy, so you've done the general skin inspection, you've decided, you've marked the lesions, okay, I want to monitor this, and this, so you'll be doing dermoscopy. So when we talk about skin lesions, just generally speaking, they are melanocytic, so pigmented skin lesions, and non-melanocytic, and you want basically, without making it too complicated, this is the one that you want to catch, right? So the main role of a melanographer, if you can just choose one, is to help the physician or the clinician to catch this early, so that when it's, if you see that it's evolving on the picture or the sequential dermoscopy that I'll talk a bit about later, we are able to catch that melanoma early before it spread to other organs. So that's the primary purpose. So with dermoscopy, you have non-polarized and polarized device, and a lot of devices these days have got 2 in 1. So you just normally there is a button where you just press it and it will change from one mode to a different mode. And the way it's different is basically, so non-polarized, it requires skin contact and fluid immersion, whereas polarized doesn't require skin contact or fluid immersion. And the major differences is just the structures, which structures are better visualized under which mode. So I'll show you some pictures in a sec. So for the non-polarized mode, it's better to visualize superficial structures, peppering that you see in melanoma, blue-white colors, again in melanoma, milia-like cysts in seborrheic keratosis or HWAT, comedor-like openings like in seborrheic keratosis. Whereas polarized mode is better to visualize deeper structures, so things like pigmentation, red-pink colors, white shiny structures, and vessels. So this one is with non-polarized, and this one is with polarized. As I've mentioned, with polarized, you see the white coloration better, and you can appreciate that sort of the white hue over there, where the arrows are pointing, are better visualized with the polarized mode. And this one, so this one you can see that the vessels and again the white structures, they're better visualized with the polarized mode. You can still see it under non-polarized, but it's just better visualized with the polarized mode. And this one is milia-like cyst, so this is a seborrheic keratosis or HWAT. And as you can see, the milia is a lot better under the non-polarized mode. So when you've just started to use the dermatoscope, you can, feel free to play around with it. And over time, you don't have to remember which mode do I use. You will just, I think you will know automatically, okay, I can see the milia, that's okay. So with dermoscopy, the colors mean a lot. So the deeper it is, so normally we are just looking at this one, because the white blue, why are we worried about the white blue coloration when we talk about melanoma lesions? It's because we know it's gone deeper. So if you see something that's brown or dark brown or black, not that you're not worried, but you know that it's more superficial than the white, sort of white blue coloration. So that's why you're kind of, oh, okay, this is an urgent lesion to be reviewed. It's got that dark, blue white hue. So another thing to think about when you are doing dermoscopy is the vessel patterns. So there are a lot of vessel patterns. So I don't want this slide to overwhelm you, because again, as I said, the more you do it, the more it becomes traumatic. Like you said, okay, this pattern, this is what it means. But if there's just some, so you've got, all sorts of different patterns, but if I can just point out the few ones which I think will be useful for you to remember. Melanoma, because again, we are worried about melanoma, right? Like with melanography, you want to catch that early melanoma. So if you've got, point J over there, polymorphic. So polymorphic is a lot of different vessels. If you see so many different vessels types in one lesion, you are worried about melanoma. So things that are erratic, just remember, okay, just make sure that's not melanoma. And dotted vessels as well. Dotted vessels are found in other things. So melanoma can be amelanotic, and that's the one that is a bit harder to catch. And so that's why these patients, if they see you for melanography, often, again, depending on where you practice, we will still advise them to see their regular clinician to get a skin check. Because, it's not your job to identify all the skin cancers or everything. So, the amelanotic melanoma is a bit harder to detect. They're colorless, and often what we see can be as easy as just dotted vessels in that lesion. And some of the, the rest of them are quite, it can be found in a lot of things, but arborizing, point F over there, is quite specific for basal cell carcinoma. Having said that, not all basal cell carcinomas have arborizing vessels. So I think the frustrating things with dermoscopy is that it's not always textbook-like, and then you see one thing and you think, but that's not what I look like in the previous examination for that patient. It can vary that much, and that's why, the more you practice, the more better pattern recognition you develop. So, okay, there should be an algorithm, right? Because it's quite tricky. Everything, if you have a good system in place, I think it will help you, especially at the beginning. There's so many different algorithms. If you do a quick Google search, or if you look up different textbooks, there's so many. So choose one that you think will work for you. But I actually quite like it because this one, the 3-point checklist, especially if you just start, is quite simple. It doesn't take, forever to start thinking, okay, there's like a 7-point checklist and a lot of different, algorithms, but this one is quite easy to use. So a 3-point checklist, if you score 2 out of 3, they're suggestive of melanoma, basically, or they would recommend excision to rule out melanoma. So under the 3-point checklist is asymmetry of color and structure, atypical pigmented network, and blue and or white structures. So we'll have a look at some pictures. So this one over here, it's quite, it looks quite good. So this one has a total score of 0. It does not have that asymmetry, does not have that atypical network. So we're talking about like the network, like the lines and with irregular thickness and coloration, doesn't have that. And it doesn't have that blue-white structures, and it's quite regular. So this one is benign. So you move on. You look at this, okay, I don't want to monitor this lesion. It looks totally benign. So this one, okay, just look at it and like, oh my gosh, like what is happening there? But with the 3-point checklist, you can basically see there is significant asymmetry. There's no atypical network, but as I've mentioned, you worry about those blue-white structures in melanoma, and we can definitely see that, quite obviously in a few different places in this lesion. So total score 2 out of 3, you worry about it, and yes, it is a red flag. So in this case, though, this is the kind of thing that would escalate directly to the managing clinician. So this one, it is blue. As I said, not everything that, it's blue, but I thought Marlene said if it's blue, it's melanoma. So blue coloration can be found in other things. This is actually, it's got the blue-white structures, but this is, not only it scores only 1, but this is actually, it's a blue nevus. We see it quite commonly, completely benign. Don't need to worry about it. And so this one has asymmetry, an atypical network, so atypical network is the one at 7 p.m., 7 o'clock over there. So that's what we call atypical network. So it lines with darker, sort of looking very different, doesn't really blend nicely with the rest of the lines. And it has that blue-white structures or white structures in the middle. So score 3 out of 3, so you do worry about it. So this one, it's quite symmetrical. It doesn't have the atypical network, doesn't have the blue-white structures, and so this is benign. Another photo, this one looking quite asymmetrical, has that atypical network, especially the one in the middle. I don't know if you can see, but it's quite dark in the middle. Don't have the blue-white structures, but score 2 out of 3. So with the one over here, this is going back to, because it doesn't look completely malignant. Having said that, if I have something like that, because my moles are quite small and they're all just like little dots, if I have something like that, I will worry about it. But if in someone whose the rest of the moles look like that, but not quite, like they all look quite irregular, but this one, it's got that atypical network in the middle. You don't have to freak out straight away. So you can decide, okay, it really depends on the patient's remaining moles. You may want to just monitor, or if I have someone who doesn't have a lot of moles has something like that, that's a red flag. So special sites. So dermoscopy, the pictures that you see under dermoscopy, it differs according to which body site. So for example, the pictures that you get for the body will be a bit different from what you see on the face. So facial melanocytic lesions, so facial melanoma, we call it lentigo maligna in the early stage, or when it's become malignant, it's called lentigo maligna melanoma. So lentigo maligna is actually quite slow growing and it develops over a number of years. So normally in the clinic, if we suspect lentigo maligna, because clinics are normally overbooked, right? And then if we suspect lentigo maligna, so not lentigo maligna melanoma, but lentigo maligna, normally we've got that a bit of a bigger leeway. Okay, the patient can wait a bit more before it's excised because it's actually slower growing. We just want to rule out that it's not lentigo maligna. So features to look out for, so any of these patterns will be concerning and may indicate melanoma. So you look for the annular granular structures. So this is the annular granular structures. Asymmetrically pigmented follicles. So if so like any of these variations, or if you have rhomboidal structures or any gray pseudo network. So this is just remember all of these 4 criteria. And this one in particular, it's got that asymmetrically pigmented follicles. So the follicles are the ones, this one, all the white dots. So they are the follicles. And you can see that there is asymmetrically pigmented follicles. So you are concerned about this one. And then the next one, so this one has that annular granular structures and the rhomboidal structures. And so again, you worry about this one. And this one, it ticks 3 out of 4. You've got these rhomboidal structures. And then this is the gray pseudo network. And it's got a lot of rhomboidal structures and gray pseudo network as well. So that's the face. Now we're moving to the palms and soles. The palms and soles, again, it look quite different. So there are a lot of different patterns, but I think if I can just tell which ones will be most concerning, normally we talk about this one, the furrow versus ridge. So the furrow is when you have those thin lines, and this is the ridge. So basically, when actually it looks pretty nice in this cartoonized version over here, but in real life it can be quite difficult to sort of notice the difference. But the way you sort of note the difference is in furrow. Do you see these white dots over here? So that's the follicles. So with furrow, it doesn't cover the white dots. Whereas the ridge, because it's a lot thicker, it will cover those white dots. So when we look in the real life picture, because at the first glance it can be quite difficult to differentiate between the two. But if you look a bit more carefully, I don't know how well visualized it is on the wall, but if you look a bit more closely, you can see a lot of white dots over here. So you don't worry about that. Whereas in this one, the ridge, it's a lot thicker. Sure, there are a few little white dots, so the follicular opening, but for the majority of it, you don't actually see it. And so this one you worry about, this one you don't worry about. So this is, as I mentioned, there are a lot of other patterns. So if you see something like this is quite symmetrical, normal coloration, you don't worry about it. Again, this is considered a benign pattern. Now, lattice-like, it goes under the benign pattern category. I have to say though, if I see something like this, again, depends on the patient's remaining moles, I may want to monitor this just because if you look at the network over there, it's not completely symmetrical, it's a bit irregular. And I think sometimes, sometimes people think, do I monitor or do I not monitor? If in any doubt, just monitor it. What's the worst thing that's gonna happen? Probably just gonna take, 10 more seconds to have to take a picture of it at the next visit. But at least you don't sort of go home, should I have monitored that lesion or how if that turns into melanoma? Worst case scenario, just monitor it. And so talking about nail now, nail melanocytic lesion is also called melanonychia. So you have benign and malignant. So if you, patients with darker skin type, it's not uncommon for them to have pigmented lines on their nails. And normally, it's not just one nail though. You will see this pigmentation in multiple nails and they look quite thin and quite regular, so you don't worry about that. But I just want to mention it's quite common in patients with darker skins. So if you see that, not all pigmentation on the skin is melanoma. It can also be caused by drugs like minocycline. So what do you look out for in the case of melanoma? So melanoma, because it's a disease process, it can cause nail dystrophy or destruction of the nail. And you look for pigmented parallel lines with irregular. So as I mentioned, the key is always irregular, chaotic looking, irregular coloration, spacing, and thickness. And one of the telltale is Hutchinson's sign. So Hutchinson's sign, so normally it will grow distally and then it goes back, right? Like proximally. So Hutchinson's sign is when the pigmentation has reached the proximal nail fold. So this one is benign, so you can see that it's quite homogeneous. Whereas these ones, they are all melanoma. So this is nail dystrophy when, it must have happened for a long time and it causes destructions and it has gone deeper as well, causing this look. And with this one, you can see that there's a lot of, there are lines, but they're all irregularly spaced and the thickness are all different. And this is Hutchinson's sign. So you can appreciate that the coloration is not just on the nail, but it's gone back all the way to the nail plate. In fact, for this one, it has gone to the skin as well. So these patients will require nail biopsy to rule out melanoma. So pigment on the skin, I'm sure at some stage you will see this. If you haven't, you will see this sort of like scattered looking or purplish coloration. So this is actually subungual hemorrhage. This is not melanoma. It's usually trauma-induced. So patient may or may not be aware. So things like ill-fitting shoe can cause this as well. And patients will say, they will be adamant, I have not had any trauma, not sure what happened. But that can happen. Often they just don't realize. However, having said that, sometimes if it keeps coming back, it can indicate an underlying disease process. So underlying melanoma can cause this as well. So normally you would want the patient to, if in doubt, photograph, but you would want to expect this coloration to fade over time. It can take a couple of months, but if it keeps coming back and the patient has said, I've changed my shoes, there's no trauma, in a small proportion of patients, it can indicate an underlying malignancy. So just be aware of that. So other common lesions, so we've talked about melanoma. So when you see patients, I just want to talk about some other common lesions that you will see. So the first one is seborrheic keratosis. So especially if your patient is in the older age group, they're also called wisdom spots or age warts. So some of the most common features, they're milia-like cysts. So this one's the white spots over there, or irregular crypts, fissures, ridges, when it's become, thick. And all of these things, so fingerprint-like structures, fat fingers, hairpin vessels, these are all seborrheic keratosis. So solar lentigo is completely benign. It happens from sun exposure. So on dermoscopy, you will see a pretty symmetrical coloration, homogeneous pigmentation. And one of the most common ones, so you don't always find this, but sometimes when I see it, I get excited and I show people. So moth-eaten border, that's quite typical for solar lentigo, and that's, when you know that it's benign. So BCC, when I first started, I thought, because I remember, BCC, arborizing vessel, pearly nodule. And then I saw patients in real life, maybe, I don't know, 1 out of 10 patients would look like that. And most of the time they're pigmented BCC with this large blue-gray ovoidness. And sometimes it's just like things like this. I just want to remind you, it can look really different from what I show to you over here. There will be some features, but you just need to see a lot, because I think when I first started, I got taught in medical school, I was taught pearly, nodule, arborizing. That's what you see for, look for BCC, but it can look quite different. So you can find these shiny white blotches and strands. Sometimes it can be ulcerated as well. So anything with ulceration, SEC, BCC, anything with ulceration, you worry about it, because that just suggests a sort of a deeper disease process, or it's been there for a while. Blue-gray non-aggregated globules and spoke wheel-like structures over here. They are all, so there are a lot of different types of BCCs out there. So BCC, vascularization, I just want to mention, because sometimes you look at patients' face, some people have a lot of vessels, and that's completely normal from sun exposure. And how in BCC, or just cancers in general, how the vascularization is different. It is sharply in focus. So you look under your dermatoscope and it's so sharp. It doesn't blend nicely. Like if you look at this vascularization over there, so that's the patient's normal vessels. It's quite, it's quite vague, and it blends nicely with the remaining skin around it. Whereas these ones in the middle, as well as these ones, they're quite sharp. And you look under the dermatoscope and you just notice straight away, it doesn't look quite, it just doesn't blend nicely. And that's the thing that differentiates the vascularization in cancers or BCC compared to the patient's normal vessels. So this is BCC, as I mentioned, some of the features, arborizing vessels. So arborizing is tree-like, or like branching-like. And then you see the blue-gray globules, blotches, and it's got ulceration over here. And this just over the corner, you can see this is what it looks like. As I mentioned, it doesn't look like the pearly white nodule that you normally hear about. And this one, again, this is a pigmented BCC with nice spoke wheels on it. So that's BCC. So the next one of the other common skin lesions is squamous cell carcinoma. It used to confuse me a lot because people will talk about actinic keratosis, sunspots, Bowen's, SEC in situ, invasive, and I was just like so many different terms. So now I've learned basically just to make it really simple. So when you talk about the cancer of this layer or part of the SEC, think about precancerous and cancerous. So precancerous, you have actinic keratosis. Normally, they will be called solar keratosis or sunspots. So that's the early stage over here. And when it's become deeper, right? So you have the early cancer, the early SCC, so also known as SCC in situ or Bowen's disease, or sometimes they are called intraepidermal carcinoma or IEC. And when it's become, it's invaded a bit more, that's when you just hear the term SEC. So basically, precancerous, you have actinic keratosis, sunspots, or solar keratosis, and it progresses further to SCC in situ or Bowen's disease or IEC, and then it becomes the SEC that you commonly hear about. So actinic keratosis, Normally, so this is under dermatoscope, but normally in patients, especially if some of you have done a lot of cryo as well, you will know that it normally looks like this with a sort of hyperkeratotic center. Under dermatoscope, especially when it's early stage, you can see this strawberry pattern. So you've got this sort of strawberry-like, and you've got follicular opening. So this sort of early-ish, and then this is the later stage. So Bowen's disease, normally it can look really different, but normally based on my experience, what I've seen is, the telltale is glomerular vessels. So all of this one, all these arrows, and this one, I don't know if you can see it, but especially this one, you can see glomerular vessels. So it's like when it looks like that, sort of like spirally. So that's what we call glomerular vessels. So SEC. So I have to say, when I look at patients' SEC, we don't really, with the dermatoscope, it's not the most useful thing. Normally just look at it and like, oh, that looks like SEC. And normally they will have this sort of hyperkeratotic center or central keratin. But under dermatoscope, if you look at it, they may have white circles, structural areas, blood spots, and again, ulceration if it's been going on for a while. And the vessels are quite variable, so you don't need to remember what vessels you will find in SEC. So again, with this one and with all, melanoma is normally not painful, but just any other non-melanoma skin cancers, sometimes it can be hard. You don't know if it's a scratch or if it's, a sunspot or if it's an SEC. Just so palpate it and ask if it's tender. If it's tender, you do worry about it, and normally we will, just let us know, and we'll do a biopsy because we want to rule out SEC or BCC. And so this is what it looks like. So the central keratin. So keratin under dermatoscope, when you have keratin plaque, it's yellow in color. And again, you see this keratin over here and the white circles that were previously mentioned. So these are all SECs. And so other skin lesions that you may find in a patient, and these are all completely benign, but I see them quite often. So blue nevus that I have shown previously. Cherry angioma, I'm sure you would have seen it. Normally it looks like pink or red papules or macules. And with this one, hemangioma, so you see red-blue lacunae. And this one is pretty common. I see it's not that uncommon. Normally, so this is dermatofibroma and just fibrous growth. They're totally benign, don't normally grow, don't normally cause any problem. And you will have this sort of central white coloration. And they're normally located on the lower legs. Can be found anywhere else, but normally on the lower legs. So now that so that's the whole thing. Just to remind you again, we've done the total body photography. We've looked at the patient and marked which lesions we want. And that's sort of an overview of what dermoscopy may involve. So you've done, for patients whom you are following up, so if you've done this kind of thing before, you will be doing sequential digital dermoscopy. And what it means is basically, you do dermoscopy at the baseline, right? So you've decided which lesions you want, you've done the dermoscopy, the patient comes back again. So for whichever lesions you monitored or you decided to monitor, those lesions need to be taken a photo of again at their next visit. And so how it works is then the doctors will be having a look at these dermoscopic pictures and will say, okay, that's benign, continue, or that's suspicious, it's evolved, we want to cut it out. So for this one over here, so this is, if you remember, I spoke about the Vectra 3D machine. So this is what it actually looks like, and on the screen you can actually play it around. So for this particular lesion, this is from a journal. So you can see that, so this is just sort of, this is just a zoom in of what that lesion, and this is under dermatoscope. This is the initial May 2016, and then September 2016, it looks the same pretty much compared to May 2016, and then the patient was seen again in February 2017, and it has obviously changed. So this kind of thing, normally we worry, we will say, okay, let's excise. We don't want to monitor it anymore. We want to take it out because it's evolved. So you can see that there is an increase in pigment. So for this one, when it was excised, it was melanoma in situ. So that's good because melanoma in situ, early stage of melanoma, that's the goal. So this one, another sequential digital dermoscopy. So this is baseline 6 months, 12 months, and 18 months. You can see that it's enlarged, basically, again, excised, and it was melanoma. So what I want to mention as well, when I look at dermoscopic pictures, if the facility has SDD, we don't just have a look from 18 to 12 months. In this case, for example, we go all the way to the baseline, because sometimes the difference can be so mild between the current visit to the previous visit. But if there is a significant difference from baseline, that's when, oh, it has continued to evolve. We want to cut it out. So this is so when I work at Westmead, a lot of the patients were patients who have been treated with immunotherapy for their melanoma. So it is quite common that you see lightening of all the moles. So I will see then, like a few years after they have received the immunotherapy and the immunotherapy has been stopped, the moles have continued to lighten, and that's totally fine. So don't, you're not worried about it, but if you ever see it and the patient has had immunotherapy, it's quite common. So tips and tricks that I have learned is if you ever get a chance to play around with one of those machines with the sort of sequential digital dermoscopy, so use a generous, go back, that's a wobble sign. Use a generous amount of fluid, alcohol solution or gel, because we need to have a really good picture definition. Sometimes if you don't use a good amount of gel, it's actually, the quality is not good. It produces that sort of fake white coloration, and you don't know if that's concerning, or if the picture just hasn't been taken well. So yeah, it's really important. And so this one, I don't know if I can go back, let's see. Okay, and then what I will do sometimes for some papules or some lesions, you can do this test called the wobble sign. So wobble sign is found in dermal nevus, which is completely benign. And what it means is just that if it wobbles around, it means it's mobile, right? So it's not tethered to the deeper structure. So that's why it's sort of a valuable tool. So you would have seen this one. So that's the wobble sign. It wobbles quite nicely, so not tethered. That's dermal nevus, which is completely benign. Yeah, and so I've mentioned that compare the image to baseline. So that's more for us, but if you're interested, we normally go back to baseline, make sure it hasn't changed much from baseline. And tape stripping. Now, tape stripping is this. So sometimes, I don't have the before picture, but sometimes I will see lesions that have gotten darker, but they're quite black. So they're not like dark brown, they're quite black like that. And I was like, but that's changed quite a lot. So as I've mentioned, if you remember at the beginning of the talk, black coloration is quite superficial. So if there's this technique called tape stripping, it's just a, your normal tape like micropore. You can put it on and just strip it. And that's just a superficial pigmentation, which is completely benign, but you have a better picture and you look at it and you compare it with the previous picture, and now they look quite similar. So it's quite normal to have that superficial pigmentation. In some patients, they have moles that have that superficial pigmentation, but they are not actually sort of part of the deep growing that's sort of concerning melanoma-like. So if you strip it and you get that, that's totally fine. That's not concerning. So lastly, I just want to talk about how, as a melanographer, we can all work effectively, so for you and the medical team. So as I mentioned at the beginning, I just want to highlight the word facilitate. So your role is to facilitate early cancer detection through imaging, right? And so we don't expect you to make an accurate diagnosis of a lesion. So we don't expect you to come to us and like, Marlene, I'm worried about a BCC, can you cut it out? Just, even like, I'm worried about this, full stop. That's totally sufficient. And just remember that you don't make a decision whether or not to excise the lesion. You are there to facilitate that process, take a good picture, help us decide. And so your expectation when the patient comes into the room is not to perform a skin check. Because I think, and I've worked with some of my colleagues who the patient comes and they say, what is this, what is that, can you diagnose this for me? No, you don't have to do that. But just feel empowered to know that that's not your role, and that's totally fine. If you know what it is and you are confident about it, you want to tell the patient, that's totally fine. But if you don't know, then don't stress about it. As I mentioned, normally we will still advise the patients to still have a regular check with their dermatologist for an actual skin check, because the skin check is not the purpose of their melanography visit. So just focus on, especially if you just started with this melanography process, just familiar yourself with the features of benign versus malignant lesions, and the purpose of that, so just that you can choose which lesions you want to monitor or photograph. And if you have any lesions of concern, really, you know, don't need to think much about it. Just take a photo if you're worried, and you can show it to the managing doctor. And again, taking clear pictures. I know it sounds so, you know, but it's just such a crucial thing. I don't know how many times I've been so grateful that the pictures have been so good that, okay, that's what it is. Because as I said, if you don't use, the picture's not taken well, it can leave that sort of white cast where we don't know, okay, maybe that's melanoma, maybe that's not. Can you get the patient to come back and we'll have to do it again? So, you know, if you want to do all those additional things that I've mentioned previously, you can. But you don't have to. Just know what your expected roles are and what are the additional things that you are welcome to do, but you don't have to do. We don't expect you to do that. So the take-home message is that your role, again, is to facilitate early cancer detection. Just focus on differentiating benign versus malignant lesions at the beginning, and just have some understanding of the patient you are managing, whether you are dealing with a high-risk or low-risk patient, and again, the patient's unique mole characteristics, so that you can identify the ugly duckling for that particular patient. So in patient follow-ups, we compare both the total body photography and the dermoscopy imaging. Good image quality is important, and we normally compare it not just to the previous visit, but also to the baseline. And again, as I've mentioned, there is a wide variation of features for every type of skin lesion, whether that's malignant or benign. The more you see, the better your pattern recognition will be. So if you see something you don't recognize, don't freak out, just do more, see more, and learn more. Thank you.
So I just wanted to say thank you very much to Marlene. This is a Goodwill Wine, so they're part of a charity group, and so the money this time is going to the Ghana Wira Young Mothers Support Group. It's called YAMP. And so thank you very much.
Thank you so much. Thanks for inviting me.